Good afternoon, everybody. I think we'll get started. Good afternoon, everyone. I think we'll get started. All right, perfect. So welcome to our orientation. I'd like to extend a special welcome to our PGY1s and welcome back our PGY2s. And I'd like the PGY1s to take special note of the PGY2s. They're all happy and healthy and smiling, so that's a good sign. So we'll spend the next hour and a half or so just going over some of the finer details of the program. I know the PGY2s have heard a lot of this last year, but it's always good for a refresher. And I'm only talking about a lot of the common things that will come up for you throughout the year and common things that we get asked questions about throughout the year as well. So before we do that, what I'm going to do is ask our chief residents to come forward. So we've got 3 chief residents, so one for each of the Windsor program, the London Urban program, and the London Regional program. So we've got Dr. Wendy Kennett in Windsor, and we've got Dr. Daniel Sung in London, and then we've got Dr. Brenna Velker in the regional program. Are they here right now? Where are they? Not yet. Okay. Well, we will move this later in our agenda. All right, so basically, in Windsor, if you have a question, you can just unmute your mic and ask the question. If you're video conferencing on Blackboard, you can type your question, and Fred Ross will let me know if there's a question. If you're here, you just have to raise your hand, and I will answer your question too. And there will be time at the end for us to answer questions as well. I'll stick around afterwards. So I have some greetings from undergrad, and so as residents in our program, you'll all work with family medicine, with medical students when you're on your family medicine and in other services as well. And they really appreciate the teaching that you give to them. There's a few things that the undergrad program want you to keep in mind though. One is that if you're not comfortable supervising medical students, that you let your preceptor know. It's not something that's mandatory, and oftentimes we'll have the PGY2s a little bit more involved in teaching, but sometimes we will have the PGY1s doing some teaching as well. All of the medical students do have a set of objectives, and they have them with them, so you can always ask them to take a look at them, and you should take a look at them just to get familiar with them. The other thing too is that all of the students have a set of experiences that they need to show that they've done throughout their family medicine. And so what they'll ask you to do is just kind of initial that they've seen that type of patient or that they've done something. And it really is just kind of a check mark saying that that's what they've done. It doesn't necessarily mean that they're competent in that, but that they've been exposed to it. So please feel free to do that as well. And then certainly if you have any questions at all, contacting the undergrad director is certainly very appropriate, or asking your preceptor as well, and they can point you in the right direction. We also work closely with the DEN, which is the Distributed Education Network. They were previously known as SWOMEN. In some circles, they're still kind of referred to as SWOMEN, which is the Southwestern Ontario Medical Education Network. But they provide training experiences in our regional areas outside of London to our Western learners. And so a few things that they do. So they fund mileage and accommodations. They pay for preceptor fees and any rotation outside of Windsor. They also fund PGY1 and 2 specialist electives outside of London, as well as some PGY3 rotations with specialist rotations as well. So some objectives. So by the end of today's session, so this is a big objective, and there's only one, and it's really to become familiar with the major aspects of the 2 years that you've got ahead of you. And I didn't introduce myself, but I think I would have met everybody here, at least at some point during CARMS. I'm Jamie Wickett, the program director. I probably should have started with that, but. So these are some of the people in our program. So Dr. Wetmore is the chair, and you would have met him at CARMS as well. I'm the program director. I have 3 sort of assistant program directors that I work with. And again, you would have met many of them or all of them at CARMS as well. So Dr. Zeter is our Windsor program director. Dr. Copeland is the Rural Regional program director. And Dr. Chan is the London Urban program director. So with immediate concerns related to the program that you're in, you can certainly contact any of those individuals as well. Dr. Aoun is the Assistant Program Director in Windsor. Dr. Wong is our C Coordinator and Assessment Director. Dr. Grushka, the Enhanced Skills Program Director. Dr. Rubayat's our IMG Coordinator. And Drs. Leger and Burke are the Academic Program Coordinators. So if you need to contact somebody within the program, your best bet was probably to start with our Postgrad Office, and that's their email address and phone number beside it. For Windsor residents, it's Ms. Christine Gignac, and she can be contacted through your education office there. I'd like to introduce our award-winning Postgrad team that's sitting in the front row providing me support today. So I'm going to ask each of you to stand up too, because I know how you love to do that in front of a crowd. So this is Fred Ross. So Fred is our education coordinator. Kelsey Claggis you'll work a lot with her for the research projects. We've got Diane Brooks, who's one of our assistants in the program as well. We've got Sharon Story, who you probably would have gotten lots of emails from about scheduling. And Lynn Hill, who you would also have lots of emails about CARMs and, well, you'll see lots of different things. Lynn wears many hats too. So. All right, so this is one of the most important slides, is to check your UWO email, because a lot of you will have other email addresses, but we will contact you. I think mainly it's through your UWO address, or unless we have another one, but usually it's all through UWO. Okay. And then you also need to check your London Hospital's email address as well. So, you know, you may end up checking 3 email addresses. It's not uncommon, but it's really important to stay on top of those, because a lot of the important things for the program and important communications from the hospital will go to those 2 email addresses. Okay, so resources. So I have some sad news. The subscription to UpToDate is ending in September. So it won't be available through the Western Library anymore. It's sort of, the cost is sort of jointly shared between the London Hospitals and the library. And so that's ending, unfortunately. But it's not the end all and be all. There's a lot of other great resources. And so I've listed a number of them there, and they also can be accessed through the Western Library. And I suspect it's similar to UpToDate now. If you're on campus, if you're in one of the hospitals, it should be directly linking you to that without having to necessarily go through the library proxy server. So remember those, they are good resources. But that unless you pay for a subscription to UpToDate, it won't be available free of cost anymore. I've listed some good websites for clinical practice guidelines. And I believe our presentation today will be posted. Is this posted on the website? Yeah, okay. So you'll be able to access this the slides will be there. So. All right, here are some really good journals to find some good reviews and some good information as well. I always recommend RX Files for things related to medications. RX Files is Canadian. It lists pretty much every medication that you could possibly ever want to prescribe, along with starting dose, max dose, price, all of that stuff. It's terrific. And then the CFPC has self-learning modules that actually have SAMPs, which are the short answer management problems, which probably mean more to the PGY2s. That's part of the final exam in family medicine. And you guys get access to those for free because everybody gets a CFPC membership as a family medicine resident. In terms of pediatrics, these are some great websites as well. So take a peek at those. And then everybody also gets access to the McMaster Residency problem-based small group learning modules. And so those are terrific study guides. They're all evidence-based. They usually have 2 or 3 cases. They're written by family doctors and specialists collaborating together. And they go through management of pretty much, again, any kind of problem you could think about in family medicine. So everybody gets access to that website as well throughout their family medicine training. All right, so this is what our website looks like. So bookmark it on your computers. You'll find lots of useful information there. All of our policies are there, all of our objectives, everything is up there. Okay, Hugo. So Hugo is the electronic order entry system that's used here in London at LHSC and St. Joe's, but it's also used in many of our community sites, and I've listed all of them there. And so any resident who will be working either here in London or at any of those sites has to make sure they have their Hugo training, or else you won't be able to put any orders in or do anything kind of when you're on those rotations. All right, and this is the reason why they implemented Hugo, is because our writing is terrible. At least, well, mine is terrible. I shouldn't generalize to everybody here. All right, so, okay, so at the end of the day, these are all the things that have to happen to be successful and complete the program. So you have to pass all rotations, you have to complete the academic program requirements, you have to complete the residency project, complete our procedures policy requirements, our OB policy requirements, attend your faculty advisor meetings, complete the field note requirements, review and meet the residency objectives. So not only is there objectives for the entire residency, but there's objectives for each specific rotation as well. And there's links to those through the slides here. All right, so field notes. So field notes will be familiar to our residents in the London Urban Program and in some of our regional sites as well. But they'll be new to a lot of you. So the Windsor program and the rest of our rural sites. And so a field note is it's all electronic. And so it's a means to document and provide regular feedback to you, the residents. It's also a way to track progress through residency. They are mandatory for all family medicine training programs. And all of the family medicine programs across Canada abide by the standards that are set by the College of Family Physicians of Canada. And it is one of the musts that all programs have this type of assessment in place. So last year was the first year, so it was a year to test it out, try to break the system, and then make improvements. And we think we've got a pretty good field note as it stands. There's only a few programs that actually have an electronic field note, and so ours it's looking pretty good. And you know, it takes a bit of getting used to, but you know, the feedback has been positive for the most part. So a couple of things that are new this year too. So Fred Ross will do a demo for us. So we'll show all of you guys how to use the field notes. All of the procedures though will now be entered in the field notes, and that's a little bit different. But the PGY2s, you'll still need to track your procedures in your procedure log. It's an unfortunate thing that we need to do both this year, but going forward, they'll only be recorded in the field notes. And so I'm just going to pull up our field note policy here. All right, so what are the expectations? So the note can be generated either by the faculty or by the resident. And so I suggest you sort of discuss it with your preceptor and decide, you know, maybe on Mondays and Tuesdays, you do the note, Thursdays, Fridays, they do the note. You need to have, I suggest one a day, but the minimum is about 3 field notes per week. And if you're not meeting that minimum requirement, A, you'll get an email saying, hey, you haven't logged any field notes in the past week or so. But B, it may actually affect your training end date. So this is a really important piece of your assessment, and it helps to really document your progression through the program in terms of meeting the competencies. So, like I said before, all procedures get recorded there. And what we're also recommending as well is that your off-service rotations, they won't have access to your field notes, but we suggest that you still do some field notes when you're off service, especially entering your procedures in the field notes as well. You basically need your Western user ID and password, so that what you use for your email is what you'll use to get into the system. And there's some instructions here in terms of if you need help to get that, this will kind of walk you through it. So Fred, can I hand it over to you to do the demo? Oh, okay, sorry. Yeah.
So after today, you will get an email with essentially 3 links. There'll be a link to where you do your field notes and your procedures, a link to the credit reporting system where you'll log your academic credits, which Dr. Wick will talk about later. And then also I will send you the link to OWL where you'll be able to access past academic half-day slides and lectures, as well as if you are wanting to webcast into any future academic half-days that are delivered by the department, you would log in through there as well. That's the place where you'll submit your resident project as well. So you'll get an email with those links and a description, and I recommend that you bookmark those 3 if possible. Don't worry about my login here. I'm just going into a system, our test side, so that I don't mess up anyone's current field notes. But the login is the exact same. So I'm going to log in as just a generic resident that we have. Here you'll enter your UWO user ID and password. It's the one that we say you need to access the library and the other Western resources. So when you log in to the system, it's not solely for field notes and it won't be going forward, but it's the main purpose of it. When you get to this first page, you'll see on the right-hand side there's a window that has pending tasks to review. So if a faculty member has completed a field note on you, you will see that there's an action item here for you to do to review the field note. On the left-hand side are a series of places you can go. The documents is empty right now, but it's for future use. The resident assessment will take you to this screen. If you ever get somewhere else and you need to get back to this screen, just click resident assessment. And then there's a section of helpful links. And then here we have various shortcuts to 145, the Western Library. We have our postgrad contacts. We also have a link that takes you to the policies within the program, so you can access those within there. But if you want to log a new field note, you just hover over this picture, and what it will do is it brings up by default who your faculty advisor or supervisor is to create the initial one. So I'm going to pick this FAMED faculty 1 to bring up the new field note. And this is what the form looks like at the top. So the first question it asks you, it defaults to saying, is the faculty member of family medicine based? So this is, you would always leave this checked yes. Over here you can change, so if it wasn't with a certain faculty member but with a different one, it lets you bring up a drop-down list and you can select a different faculty member that you worked with for that's in family medicine. It asks to check off a series of what competencies were assessed. These will be elaborated throughout your core family medicine and what they mean. And beside each one, it has a count of how many you've done of that, had a field note done on that competency. The same with the skills. And then this is the type of review. So was it a case review or a discussion? Was it just a look at, or were you just reviewing the chart? Was it a direct observation? Or was it just kind of a conversation in the hall that you had about that specific patient encounter? Or was it one that was recorded and you reviewed it together at the end? So basically you can check off any one of those. So if I check off competencies, I'll check off hospital care just to give an example. And then I'll kind of do it at the same time here. If you click procedural skills, this is where you're going to log how you log what procedures you completed. When you check that box, so let me just uncheck it, you'll see that there's a new option down here asking you what procedure it was. If you click the little drop down arrow here, you can actually type in anything you like. Yeah, you might have to know the actual name of the procedure, like there's different nomenclature for different procedures and that, so you might have to hunt a bit. But if you go to, say, obstetrics, and I did an artificial rupture of a membrane, you just select that, and then it's going to ask you what your role was in that procedure. So if you assisted it, that's all you have to do. Then there's a section about just some patient demographics. This is just more for reporting purposes, for accreditation and that type of thing. So I'm going to pick adult. It's obviously pregnancy related. Member of an underserved population. This is a question we always get about what's that definition. This is kind of like the social detriments of health. So determinants, sorry, not detriments, sorry, determinants. Slip. So socioeconomic status, those types of things. If they're in an area that, essentially, if they are in an area that doesn't have access to full health care, that type of thing. So, and then there's an area to put in a brief encounter of the description. Do not include patient identifiers. So you could say like female, 34, that type of thing, but don't include like the name of the patient, that type of thing, or a patient ID or anything like that. This isn't meant to be a patient tracker. And then there's an area to put in like that you did well. So I just say you know, I don't know. I'll just put something in. And then you can do areas for change. I don't practice OB or medicine, so. If you don't fill out an area, when you go to submit it, it'll tell you have to go back to do it anyways. So same, you fill out areas for change, and then there's an overall assessment of that one patient encounter that day. So I'm going to pick minimal or no changes recommended, and then you just click create field note. And it's told me there that I didn't pick what type of review it was with my faculty member. So I'm just going to say general questioning of the trainee, create field note. So now I've created a field note, and I've also logged a procedure in that one step. So you kind of kill two birds with one stone. After I log that, it takes me back to this screen, where now it tells me my progress. So it's going to tell me that I have 24 field notes that are pending my review. I'm a little delinquent. There's one pending the faculty's review. And then it tells me how many have been completed in the last 7 days, or generated in the last 7 days, and then how many have been done in the last 30, and then it just gives me an overall total. And then over here for the procedures, it tracks how many that you have remaining. And then it also tells you how many are required. So I've done one based on what I selected. So I have 2 left to do with a family medicine physician. And then it also tells me how many core procedures I have remaining, and then just again how many I've done in the last 30 days. If you want to see the field note, the details of it, there's a tab down here that says field notes, and it's a listing of all the field notes. This will happen too, so I'll talk about this. You've created a field note, but you've chosen the wrong faculty that you worked with. So if the faculty hasn't reviewed it yet, which they shouldn't if they didn't work with you on that day, you can go onto this Field Notes tab, and you can actually click on the faculty's name and just enter a new one. So I'll enter Charlie Mahagan. And what that will do is that'll reroute the field note to that faculty member. So you have a chance to change who it goes to. The other thing you can do in here is when the faculty members created the field note, you can review it in here. You have the ability to, if you don't agree with the overall assessment, you can provide what you think it should have been assessed at, and you can provide additional comments, and then that goes back to the faculty member one more time to review. It's the same if you create the field note and you give an overall assessment and the faculty thinks it's a different assessment, they have the ability to give their opinion is really what it is. So, and then you just click update and review, and it'll show you that it's been reviewed by both. So anywhere where it's pending means that it has action required on it. There's some filters on this left-hand side here. If you want to get fancy, you can also do a search in this box just by, if you're looking for specific ones with which faculty member you worked on. This is a good tool for your faculty advisor meetings to do some research before. And then on the Procedural Skills tab, this will tell you which ones you've completed and how many times you've done them, and you can just click on that details button and it brings up the details of that field note so you can see what the feedback was on that procedure. If you want to create a new field note from this screen, you can go and just click new field note. It goes back in here. When you're doing procedures or field notes off service, select this to be no. It's going to ask you to just type the name of the supervisor in, and then whether they were a faculty or a resident, because sometimes you may work with a senior resident in medicine or surgery or that type of thing. This does not go to them for review. This is more when you're off service, it's a self-reflection kind of thing. So you'll just fill this out, but you can log your procedures the same way as well. So, but when you're off service, that's the way to use it for field notes. Did I miss anything? Oh, you can also, if you go back here, sorry, if you're interested, there's also a graph that tracks your field notes over time and how you're doing. So this is a graph. So the green and blue are your minimal or minor changes, and then the yellow would be areas of focused work. So it kind of shows you if you're how you're progressing over time. And then there's also a set of bar graphs at the bottom here that gives you the breakdown by those competency skills and types. So just a quick snapshot for you to see how you're doing. Oh yeah, I'll show you that too. I don't think I can do it, but I can show you. So if you're sitting together with your faculty, with the faculty member, and you're going through this at the same time, you can log in and create this. And then if you have that faculty member is selected in this box, all they need to do is enter their password. And when you hit create field note, it'll show that you've both reviewed it. So there's no second step for them to log in and go back to it. So if you're doing it sitting there together and you say, this is a great opportunity to fill one out, you can do it right there, get it done with. Nobody has to go back in to review it. So, so like Dr. Wiggins said, initially what will happen is once a week you're going to get an email reminder saying that it's going to go to everyone regardless if you have field notes to review or not, saying just a reminder to go in and check that you've reviewed field notes, that you've completed field notes if you need to. And then in the fall, at probably October timeframe, you'll start to get more focused reminders about you have field notes to review, or you haven't logged any field notes in the last 7 days, that type of thing. So that will come. That's coming in the fall as we roll out more functionality. So, any questions? So you don't have to transfer them over. Just start from now going forward. We'll monitor to see how you're. Yeah, we'll get them added together closer to when you complete the program. So anyone in PGY2 that's going to be finishing in July or later, or June or later, sorry, just start logging your procedures in here. We'll manage that as it gets closer to the end to tell you where you might have some gaps. It's kind of a transition year for your group for that. So, but for anyone that's in PGY1, all of your procedures are logged in here. You won't be able to log your procedures in the other system that you're talking about. So. Right now you cannot. You can only log. Oh, sorry, I got to repeat the question. So the question was, can you log multiple procedures in one field note? You can't. You can only log one procedure per field note. You have to make a separate field note and that. So. So the question is, will the procedures that were logged in the old system be transferred over to the new one? The answer is no, because they weren't created using a field note, and that's the driver in this system. So you don't have to worry about transferring them over. You'll be able to still see them in that old system, that when you log your credits, you can see what you've done to get a gauge for entering in the new one. But unfortunately, it's an old system that we can't make common with the new one. So. Yeah. You can ignore that on this as long as you know. So we'll have work on our part to check which system and between the two how it's all working, and we'll let you know with regular updates. So for that group transitioning. So good. And if you have any questions, you can just email myself about. Oh, sorry. Yeah. Yes, everybody has to log. As of July 1st, you have to log your procedures through this new system. Yeah, only through this. You don't have to. Yeah, the policy was written through a first early discussion. So we'll update the policy on the website for that group that's finishing, if that's clear. We're going to provide you periodic updates that will combine it because we can combine the information. So yes. So sorry, the question was the academic credit reporting is still in that old system. Next July, it'll be in here. But for now, it's so change. It's always happening. So yeah, sorry. Yep. No. Well, the idea is to do it every day, or at a minimum, be in there weekly. So we've been monitoring that over the last year. We're close to almost 6,000 field notes that were logged in the past year in the system, and most of them are done within 2 or 3 days of the actual encounter. So like we can kind of see that, and the same with the reviewing. So. You can use the field note, and I would just use either that encounter description or the notes. I would just put in the notes that what date that procedure was from to get you through that. I don't want you to lose. We don't want you to lose that credit for that procedure. So yeah, like when you see, if you put it in the notes of that description, if they need to investigate it. But in the old procedure system, you didn't get to put a date that you did it either. So.
All right. So before Fred gets out of the screen, I was going to say that so for ambulatory care, that's office-based practice. For hospital care, it could be emerge, inpatient, or OB. And then residential care is a house call, nursing home, or long-term care. Leadership would be like if you were sort of leading a meeting at your clinic or leading a family meeting, perhaps even doing some mentorship or some teaching with a junior learner. And then scholarship would be around like a teaching presentation that you've given maybe to your clinic or to your group of residents that you're teaching. So.
It's also just a sec here. If you're wondering too, you can also. Sorry, I just want to show you the website is also it's mobile friendly. So if you're going to enter field notes using your smartphone or a tablet, it automatically reformats to the size of the screen. So this is like, for example, this is be kind of what the field note would look like on your smartphone or your tablet and that. So it is mobile friendly. If you ever need help on a screen, if you click this help button, it highlights a bunch of areas, and then it gives you a brief description at the bottom, obviously. Yeah. So just, if you click on that skills, it gives you like a further definition of them. So you can always just click that help button on any of the screens, and it'll tell you what works, how it works.
Great. Thank you, Fred.
No, that's how many have been. Sorry, the numbers in parentheses are the number of when a field note was created. It logs, it tracks how many have been created for that competency. So in that, when there was like 11 in the brackets, it's saying that there's already been 11 field notes that have indicated that competency as something that was being looked at. For field notes. For competencies, no. There's no like set like distribution between those 6 competencies.
Yeah, and the expectation for each of the competencies and the skills is basically that there'll be an adequate sampling across all of them. And our experience so far is that's what's happening. So when we sort of graph out all of the competencies that are being assessed, all the skills that are being assessed, and all of the types of encounters that are happening from direct observation to sort of chart review and discussion. It's pretty equal across all of them. The only one that's been quite small is the taped encounters. So people are more reluctant to tape themselves, but hopefully that will increase as well. So, all right. So, okay. So what does a typical rotation look like? Well, each block, we talk in blocks now in residency, and so each block is 4 weeks long. And there are 13 blocks per year, or 26 blocks in your entire residency. And the typical changeover day is on a Tuesday. And the exception only is your core family medicine and your rural FM, which are longer, and again, depends on which program that you're in. These are all of the PGY3 enhanced skills programs that are offered. These are all offered. It doesn't mean that there's always a resident in them each year, but it's quite an extensive list, and we're lucky to have a very strong enhanced skills program here. So, and also an award-winning enhanced skills program director too. So. Okay, so how do you successfully complete a rotation? So basically, an ITER is your in-training evaluation report, and that's the assessment that you get at the end of each block. And so there's 5 different categories that are outlined there. So to successfully complete the rotation, you need to either have meets expectations or above that. An unsuccessful rotation is either unsatisfactory or does not meet expectations. Or if you have multiple borderline evaluations, that could also be a reason for implementing some formal remediation. All right, so what happens? So if you get either a borderline or a failure, a notice is sent to myself through 145. Typically what we'll do is we will arrange a meeting between myself or one of the program directors from whichever program that you're in. And we meet to discuss that evaluation and sort of the circumstances around it. If it is a failure in terms of does not meet expectations or unsatisfactory, then this does require formal remediation. Schulich postgraduate medical education does have an evaluation and appeals policy, and so it is possible to appeal any failure of a rotation. And really, anytime there's going to be any type of formal remediation, you can also appeal that. The link to this policy is on our website, so we have a nice section about policies, and that is there. So just make sure that you know of that policy. Also with borderline, the alert gets sent to the program. We often will do the same again, arrange a meeting. We have a postgraduate executive committee, which is made up of all of our program directors in family medicine, as well as the chief residents. And so we meet monthly. And so a failure or a borderline would get discussed there in terms of management and come up with a plan that then gets communicated to the resident as well. All right, so in terms of how to have a successful rotation, well, so A, make sure that you know what the objectives are and what your own personal objectives are. Be your own advocate. Make sure that your preceptors know what you're looking for in that experience. It's true in all rotations, you know, and especially in community-based rotations as well. It's important that they have a good understanding of who you are, where you're at kind of in your training, and what you want to be doing. All right, so selectives and electives. So selective, which is a core rotation, can't be changed once it's scheduled and confirmed. And these rotations are limited to within Southwestern Ontario, whereas an elective can be taken outside of Southwestern Ontario, and we'll talk a little bit about how one could go about changing those. And so you can only take a maximum of up to 3 rotations outside of our region. So our region is LHINs 1 and 2. So a LHIN is a local health integration network, and I'll show you a little bit of a map, kind of what that looks like in a minute. All right, so in terms of electives, so we talked about not being able to change core rotations and core selectives. And this is because there's a set number of rotations. It is a lot of work to schedule all of those, and it's extremely challenging to be able to change them. And those are rotations that you absolutely have to have. Electives, there's a little bit more flexibility. Has to be, though, before 4 weeks of the start. And you have to fill out a rotation change request form. And you have to get acceptance from the service that you were scheduled to be with, or the rotation that you're scheduled to be with. And then you need to get acceptance from the new rotation that you're requesting. So there is a bit of work involved in that as well. And then you have to let Sharon Story know that you've gone ahead and made those changes to your schedule. So some other types of electives. So there's the research elective, which is where you take one block and dedicate that to your research project. There are requirements for that, and that's in our website, and you can take a look at what that involves. You can also do a vacation elective, so where you can pool all of your 4 weeks of vacation and take one full block off. You can actually do one block out of province, or well, really out of the country as well, if you wanted to do some international work. And here are LHINs 1 and 2 that I alluded to earlier. So you can see it's a fairly broad area, but anything outside of LHINs 1 and 2 would count as being outside of Southwestern Ontario. Yeah, so the question is, for rural residents, especially, does ROMP count as being outside? So yes, it does, although, so rotations, like core rotations that you're doing at Owen Sound, so that Owen Sound is actually still part of Southwestern Ontario. And it wouldn't seem like it, but it does kind of extend that far. Were you thinking of other rotations specifically, or? Yeah, so that, for those core rotations, if they were to be in Collingwood, that would still be considered within our, or would it be considered outside of? I guess that's a good question, because it's, yeah, I'm deferring to my team of experts here. That's true. Yeah. So yeah. Yeah. Okay. So, are you a Hanover resident? Okay. So yeah. So if you're a Hanover resident, that wouldn't count as one of your 3 outside of Southwestern Ontario. But for everybody else, yes. I was thinking that you were Hanover, asking those questions. Yeah. All right. The other thing that's available too are special interest electives. So there's one special interest elective that's established and has been running for many years now, and it's offered by the emergency medicine department. It's mainly the CCFP EMs that are offering that, and it's completely simulation based. It's really cool. And they run it yearly, so you'll get an email that will come out that will tell you when it's happening and how to sign up for it. But you can also design your own special interest electives, and so there is, of course, a policy for that too, but it's more just to kind of guide you through the process. And basically you have to outline sort of what the elective would look like, how many people would participate, what the topic would be, who would be sort of, offering or like being the presenter or faculty person, and also the budget certificate that would go along with that, and then you would submit it to the program and it would get reviewed. So we've had some interesting things over the years. A few years ago, there was one for chronic pain. We've had some for psychotherapy. So we're always open to getting new proposals, so just keep that in mind. Okay, so for horizontal electives, Windsor has a separate horizontal elective policy that I'm sure Dr. Zeter will share or has shared with the Windsor residents. In London, at this point right now, if you're a PGY2 resident doing your core family medicine, you can do up to 6 half-days outside of your family medicine core rotation, doing any type of horizontal elective. Now, you have to arrange it. But you know, residents have done lots of different things. Like people will do some rheumatology, some dermatology, infectious diseases, travel clinics. So it's really quite broad, all of the experiences that you can get during that. You just have to discuss it with your preceptor and then just make sure that your schedule at the clinic reflects that you will be out of the office. All right, so all of our residents that are in the London or Windsor programs have to do 2 months of rural family medicine. And again, this is a mandatory requirement based on the CFPC guidelines. We have a whole list of eligible rotations on the website. And there's just a few caveats. So one is that it can't be in a city or town where there is a tertiary center or academic center. And that it usually is sort of with a preceptor who works in 2 or more settings, which the majority of physicians do anyhow. All right, so I'm just going to move on to our academic program. And so we have a unique academic program here at Western, which I think is kind of cool. And our focus is really on giving you guys flexibility as adult learners so that there are some mandatory sessions, but there are also a number of afternoons where it's self-directed learning. And so this is to model sort of real life CME, sort of what you would be expected to do once you've left the program, but still have to maintain your certification. And so what it looks like is that there are 150 hours that need to be logged each year of residency. So 1 hour equals 1 credit. So at the end of it, you'll have at least 300 credits. Most residents have more. And again, this is a means to sort of record the learning that you're doing and what you're doing. It's all logged online. You can claim credit for CME activities. If you are going to a CME activity, you need to keep your certificate. As a measure of quality control, we do random audits on a handful of residents in PGY1 and PGY2 over the course of the year. And so if that happens, what we would do is we would ask you to provide those certificates of your proof of attendance. All right, so what does our academic program involve? Well, it involves a few different branches. So one are the academic half-days, which I just spoke about. Our schedule is posted on the website and it always outlines where you're supposed to be and when. And it's protected time every Wednesday. So even if there isn't a mandatory half-day, you still have that protected time to pursue your academic endeavors. In a couple of slides, we'll go through some of the other branches. So sticking with the logging here. So this is also on the website under the academic program. I'm just going to quickly highlight some of the things that you can claim credit for. So reading, so any of these sources here. Attending educational sessions, so those that are organized during your family medicine block time. Any kind of accredited conference, course, workshop, whether it's online or in person. Hospital rounds, departmental grant rounds. If you're working on research or publication outside of your resident project. If you attend any of these specialized training courses, you can claim that as credits. All of the centers will do practice audits. And that cannot, so the ones that are mandatory for your training can't be logged. If you're doing that above and beyond, you could log those. And then, of course, the academic half-day sessions, those would count for that. You do have to log those in as well. It's not automatically tracked. And the other thing, too, is that you have to fill out, in order to get credit, you still have to fill out the evaluation within 2 weeks of attending the session. All right, so academic half days. So like I said before, so one Wednesday afternoon per month. There's usually 2 to 3 topics that are covered. Attendance is mandatory to those ones, and attendance is taken in person as well as electronically. So our guidelines are that if you are on rotation within 40 kilometers of London, then you need to attend in person, and they're always held here in this room. If you're outside the 40-kilometer mark from London, then you can attend by webcast, and the details for that are sent out with the link. All right, so as Fred said, he will be sending out an email that will have the information on how to get logged into our academic half-day credit reporting system. And like I mentioned too, just a couple of random audits per year. Every December and June, you'll get an email saying kind of where you're at in terms of logging the credits. And that's just a good reminder to get things in. It can be tough, and my sense is that our new system will have some different features that will make it a little bit smoother to log. And then we say, well, yeah, try to complete the credits about a month before the program end date, because it is one of the mandatory requirements that has to be done before we can really officially sign off. Yeah. So the question is this different than logging in 145? So yeah, the academic credit reporting system is a separate logging system from 145. Yeah. So I think last year the credits used to be linked, like if you filled out the evaluation form, it would get automatically. Yeah. Yeah, but this year you have to actually go into the academic credit reporting system and log them there. All right, so yeah, so the evaluations are sent by 145 and need to be done within 2 weeks. So another branch of the academic program is the ethics curriculum, and we're lucky to have Mr. Robert Sibbald, who is an ethicist at LHSC, be the instructor for that. And so everybody will get a 3-hour session when you're on your core family medicine rotation. And again, this is also a mandatory session, and there is a similar program that's offered in Windsor by a different facilitator or coordinator. We also have a palliative care curriculum, and so we have 2 3-hour seminars that are offered during the academic half-day time. And again, mandatory attendance. There is a similar program that's offered in Windsor by different instructors. And the schedules are in 145, but they're also on our website as well. If you look at specific curriculums, you'll find them there. All right, and behavioral medicine is our curriculum that we offer that helps teach a lot of the mental health topics that you would come across in family medicine. And so it involves not only academic half-day sessions, but it also involves small group learning sessions at your family medical center. And there's going to be some good changes coming up for this year. So each session will have a slightly different focus. So some will focus on interviewing and communication skills, but there'll be more emphasis placed on other topics as well, such as mood disorders, chronic pain, addiction, chronic mental illness, chronic disease, and behavior modification. And Dr. Sadia Hamid has been instrumental in really revamping the whole curriculum, and it's looking really great, and there's a lot of good energy, and she's been collaborating with psychiatry, and so I think this is going to look like a really neat program. And again, the Windsor residents also have a similar behavioral medicine curriculum, but it's given by other preceptors in Windsor. Okay, so transition to residency series. So this is for all PGY1 residents, and it's offered through PGME, which is the Postgraduate Medical Education Office. This curriculum gets excellent reviews. They've put a lot of hard work into it, and I think you'll really enjoy it. It's most Wednesday afternoons for the next couple of months, and it really just focuses on those sort of key areas, those kind of scary things that you encounter as a PGY1 resident when you're kind of running the show now. So things like chest pain, shortness of breath, all of that stuff, and how to manage and how to work through it. All right, so CQI is another branch, or continuous quality improvement. And so with the resident research project, or with the resident project, you can either do a formal research project, or you can do a quality improvement exercise, or project. But there are 6 modules that that every resident has to work through, regardless of whether you're doing a research project or a CQI project. And our deadline for getting that done is the first week of September, and it takes about 8 hours to get done. And so that's probably one of the links that's going to get sent out with the other email too. Is that usually? Okay, Kelsey's going to send that out. Okay. All right, so resident project, as I alluded to, is either a research project or a CQI project. You work in groups, or you can work in groups. You don't have to. You can work individually as well, and it can be up to 5 residents in your group. What happens in PGY1 is that you submit before the end of your PGY1 year. Sooner if you have it done, like if you've got it done with your group by the end of your family medicine block, you can send it in. In PGY2, there is a progress day that you report back to. You have to have your project done by the end of March in your PGY2 year, and then there's a presentation that gets done at our annual resident project day. And this was our first year presenting the CQI projects, and it went really well, and there's been a lot of great work done. So. All right, so Fred talked a little bit about the procedures, but there's a list of core procedures that need to be accomplished. And so it's not absolutely necessary that you've performed each of them, although most of them, surprisingly, like when you look at the list, it's an extensive list, and you actually will get the opportunity to do the majority, if not all of those procedures during the 2 years. If you haven't had a chance to complete it, there's a number of ways to go about becoming familiar with it. So one is to read about it, to watch videos about it, to sort of go through it with your preceptor, even kind of do a simulation. We also offer teaching sessions during the family medicine block time where you'll learn some hands-on procedural skills. All of our centers also have access to either a textbook or a website called Primary Care Procedures, and that has an extensive list of procedures as well. And I suggest all of you get familiar with that also. The other thing that we're happy to offer, and so the PGY2s would have done this curriculum last year. So it's a PGY1 curriculum, and it's an OB procedures simulation day. And you do everything from rupture of membranes to cervical checks to delivering a baby to managing a postpartum hemorrhage. And it's really cool. We get a lot of our FMOB faculty here, and they each run different sessions, and you rotate through each sort of station in small groups. So that will be in the fall of this year again. Okay, so the obstetrics policy is that you will all do a minimum of 3 deliveries with a family medicine OB preceptor. So sometimes this experience is easier in, let's say, London, Mount Bridges and Strathroy, Hanover, Goderich, Chatham-Kent, and Stratford, because a lot of the preceptors there, the family medicine preceptors there, do OB. Petrolia, Windsor, Ilderton, it's a little bit more challenging because the core family medicine preceptors don't do OB there. So what does that mean for those residents? Well, what it means is that there are still opportunities, and so you need to speak to your preceptors about how to go about getting that experience, and also needing to take advantage of either your rural FM rotation or other elective experience with a family medicine preceptor that does OB. And so if you're having challenges with that, let me know early on or talk to your preceptor early on, because what inevitably happens is you get sort of towards the end of your second year and you've only got maybe one with the family medicine preceptor, then you're kind of scrambling. So just make sure that if, by the halfway mark or into the second year, if you don't have that, make sure that you have a good plan in place to be able to get that. Yeah, Jeff?
So are you saying, part of 40 or 50 deliveries during kitchen rotation?
Yeah.
That I still need to do a family medicine preceptor one separate?
Yeah, so the question is, I've done so the Kitchener rotation, you get tons and tons of deliveries, but it's all with obstetricians. And so yes, that's absolutely great because you've gained a lot of skill and expertise with that, but it's still important to have your 3 deliveries with a family medicine mentor and preceptor. All right. So, and with the OB experiences, so not only do you need to log the experiences with family medicine preceptors, but you also need to log those with obstetricians as well. So just make sure you log absolutely everything you do with respect to OB in the field notes. Okay, so everybody is assigned a faculty advisor when they start the program. By default, your faculty advisor is your primary preceptor. If you'd like a different faculty advisor, let us know and we can make arrangements for that. We also do have a confidential mentorship program, so if there's something that you didn't feel comfortable talking to your preceptor about, then you can always access a different advisor. But the goal really is just to help mentor you and support you through residency. And it's also to help you not only identify your learning needs, but also help you find experiences to meet those learning needs, and just to look at your progress as you go through residency. So when you meet with your faculty advisor, you go through all of your evaluations, your logs, look at your field notes. So it's kind of a periodic review in a sense where you're looking at sort of everything, your entire kind of assessment portfolio. And so typically you'd meet within the first 3 to 6 months of residency, and then you'd meet at the 12-month mark, the 18-month mark, and then 22 to 23 months. So you'll get an email through 145 that you have a form to complete for your faculty advisor meeting. We put the responsibility on the resident to reach out to the faculty advisor to schedule that meeting. And they can take place really in person, phone, Skype, FaceTime, whatever is convenient. We just prefer that they didn't take place over email, just because you can't really have a good interactive discussion that way. And that what we'd like you to do too is really to come prepared, having reviewed your evaluations, having reviewed your logs, and having a good sense of sort of where you're at with all of those, and also having looked at the competencies and kind of reflecting on where you think you're at in terms of achieving them, and are there areas where you may need sort of more focused attention. All right, so we've got lots of policies, and they're all right here. I've gone through a lot of them. I'm just going to touch on a couple other things here. So our accommodation and travel expense policy, basically we will fund accommodation, transportation to core teaching activities for those that are off-site for rotations or outside of London. And so what are some core teaching activities that are covered? Well, the PGME Transition to Residency series, behavioral medicine curriculum, the ethics curriculum, the mandatory half-days, the courses like neonatal resuscitation that we offer. And so if it's a morning session, we will provide accommodation for the night before, and we have some designated sites where from which you can choose in terms of staying. Those are the ones that we will pay for. And if you don't stay there, we still pay up to a certain amount of what those other accommodations would cost. And so basically, a core rotation is any that's not an elective. So. All right, so if you are doing a core clinical rotation outside of that 40-kilometer radius, we pay for 1 round-trip mileage. We pay up to $600 a month for accommodation. And then you have to submit this is key, you have to submit your receipts within 60 days, or else it may not be paid. And so, I mean, I guess I could probably even take computers are not always available because everybody has a smartphone or a tablet, and kind of everyone's wired these days. So, all right, so that we talked about. Okay, so let's just talk a little bit about taking leave and vacation and whatnot. So you get up to 7 working days per year for educational days. So you can use those for any course, conference, a study day. You have to still fill out the leave request form. And so the majority of time, any leave request will usually be granted. It may not, though, if it will affect patient care. And so if you look at the payroll agreement, it outlines all of the sort of rules and regulations around that. And if you were denied the date that you requested, you're still entitled to a day, so then you have to submit a different day that you want to get approved for. All right, so we, as a program, provide funding for some educational activities. And so it's $400 per year. If you don't use it in PGY1, you can carry it forward to PGY2. And if you don't use it in PGY2, you can carry it forward to PGY3. So, potentially in PGY3, you could have $1,200 to spend on courses, provided you stay at Western for your PGY3. And again, having your original receipts and submitting them within 60 days. But basically, we would pay for any kind of educational course, a conference. For conference, it's only the registration fees. We don't pay for travel or accommodation. Does it include books? I don't think that we paid for books before. No. How firm is the 60 days? It depends if you smile when you give your receipts in. And, well, the 60 days is pretty firm. It is, yeah, it sounds like it's very firm. How far beyond the 60 days are you, Paul? Okay. I suspect if it was 61 or 62, Pat would probably let it slide. So the question is, why is it 60 days? Okay. It's the Western University finance policy. Yeah. Does it cover online subscriptions to like a course or like a conference? Well, that would be similar to a book. So no. Yeah. But if it was an online course, I mean, that would count as towards it. Yeah. Sorry, say that again. Yeah. No, so the question is, if you've done ACLS prior to the start of residency, is that deducted from the 400? No, it's not. Yeah. Okay, so vacation, you get 4 weeks per year. Typically, it's 5 work days and 2 weekend days. Ideally, you'd have your request in 4 to 6 weeks in advance because it obviously affects scheduling and in terms of the call schedule or office-based practice. We recommend that you try to divide it up equally kind of throughout the year so that you're not just taking a huge chunk of vacation in one block. And medicine has some specific instructions. Other services do as well, so just make sure you're familiar with those as well. And then you also need to notify, so you need to notify us when you're taking vacation, and there is a leave form that you need to fill out, but you also need to notify the service from which you'll be taking vacation as well. This is just something to keep in mind. So there's really no rule preventing you from taking 3 weeks of vacation on a 4-week block. But if you do that, it only leaves you with 1 week. And so typically what we recommend is you try not to take more than 1 week of vacation or 1 week of leave period during a 4-week block. And the reason for that is that it really may not give your preceptors enough time to fully assess your level of competency in that rotation. And then with a 16-week family medicine block, let's say, obviously that's a longer period of time, and so it wouldn't be unreasonable, for something like 2 weeks out of that period of time. And if it's going to be longer than that, I mean, you need to discuss it with your preceptor just to work out what would be appropriate for that period of time. So, all right. So if you work on a stat holiday, you're entitled to a lieu day. The guideline is that you take it within 90 days of acquiring that lieu day. when you submit it, it gets submitted to Diane, and what we ask is that you also include the date of the stat holiday, so we know just how to credit that and enter it in our system. The holiday time in December always gets a little bit confusing. So everybody is entitled to 5 consecutive days off. Those 5 days include either Christmas or New Year's. If you want additional time during that time, and it doesn't include December 25th or January 1st, then you'll have to use a vacation day or a conference day. And then what we also really ask you to do is take into consideration when you're, like, so if you're on family medicine during that time, take into consideration, or really any block that's sort of office-based, because typically some of the offices will close over the holidays. So take into account what days they'll be closed and try to make your 5 days fall over that day or over that time period, just so that it's fair amongst yourselves and the rest of your colleagues as well. Because it may look a little bit different, somebody who's on medicine versus somebody who's out in the community. So, yeah. Yeah, so that's a good question. So the question is, if you're doing a 4-week block over that falls sort of over Christmas and New Year's, does that mean you shouldn't really take any additional vacation time? It would really depend how much time then you're actually on service and how much time your preceptors will have to work with you, right? So if it's 10 days, like if it's 5 working days and then an extra 2, they may still have a chance to fully assess you. If you're missing 2 weeks out of 4, that's going to be cutting it a little too close. So yeah, so that is the only time when it does make it a little bit more challenging. Yeah. All right, so just a couple of things is that you actually can't take a half day. So half days don't exist. You have to use a full day. So that's for conference days. And you actually can't take an individual vacation day. It has to be 5 consecutive days. So it can be a Monday through Friday. It can be a Thursday, Friday, Monday, Tuesday, Wednesday. An academic half day is considered a working day. And so if you want the Wednesday off, then you actually have to use a conference day, or it has to be part of your vacation time as well. So religious holidays can be taken as requested and required. Again, you have to just use the leave form. Yeah.
Sorry, I have a question.
Sure.
So can you take a 1 week vacation that overlaps with 2 blocks? So like 4 days at the end of 1 block, 3 days at the beginning of the next?
Yeah, you can have, yeah. So the question is, can your vacation start at the end of one block and then run into the beginning of the next block? And yes, it can. Yeah. It's just more work for you to notify 2 services, but it can absolutely be done. Yeah. All right, so, so the religious holidays, what we recommend is that you fill out the leave form, and it usually gets documented as a conference day since it's an individual day that's taken off. All right, so parental leave, maternity leave, discuss it with your supervisor as soon as you know you're going to be taking the leave. Also let Sharon Story know. What we do, we require a written request from you, so send an email is sufficient. Also a doctor's note is required as well. And then what we do is we basically look at what you've completed in the program and what you have left and come up with a schedule for what it would look like upon your return. The caveat being, you still have to complete all of the requirements for a 24-month program, and so we go through that with you should that type of leave come up during the program. All right, so we also have compassionate leave, and so if you have some type of personal situation that comes up, for example, like a death in the family, you can take up to 7 days away from training, and they're paid days. Any additional time would need to be taken as vacation or educational leave, or an unpaid leave is also a possibility. And again, just letting myself know and your preceptor on that rotation and our Postgrad office know as well, so that we can help support you through that and also just be aware of that time away. All right, so in terms of our evaluation policy, all of our evaluations right now are done through 145. So 145 sends it out through UWO email. What you'll need to do though is make sure that you log in to 145 regularly to see what's in your to-do inbox. And because there'll be times when you actually need to pick preceptors to which the evaluations get distributed to. And so the best scenario is that you have your evaluation with your preceptor either the last day of the rotation or during the last week of the rotation. If you can get that done during that rotation, that is the best case scenario. There are times when evaluations get done months or even a year later, and that's just not helpful to you guys or to anyone really. And so if you're missing an evaluation, make sure that you email the preceptor. If that's still not successful, let us know, and we'll help advocate on your behalf as well. Okay, so the question is, who do you email if the preceptor doesn't know how to use 145? Well, email Lynn, and then we will sort it out, because that does happen. It happens that preceptors aren't familiar with it, and we can help set them up and help guide them through it. So yeah. I don't know, Lynn, is that okay if I have them email you? Okay, all right. Yeah. Yeah. So the question is, what do you do if your preceptor doesn't meet with you to discuss the evaluation? Well, I think it's very reasonable to approach them and just say, you were hoping to have some time during the last week or the last day just to do your evaluation. But it does happen where you kind of leave. I'd say the majority of rotations, though, they do make a point of meeting in person to do the evaluation. So if that hasn't been arranged, I'd make sure that you try to advocate for yourself to get that scheduled. Yep. If you check the box that says you have not discussed it with your preceptor, it's flagged on the evaluation, but there aren't any consequences. It's highly recommended that it's done in person. That way there's no surprises, and you just gain more out of that face-to-face interaction rather than just kind of seeing it, online. All right, so there is a code of conduct, and if you are noticing behaviors that aren't following the code of conduct, let myself know, one of the program directors, our Associate Dean of Learner Equity and Wellness, the chair of our department. So these are unacceptable behaviors. You don't see them happen often, but it's certainly possible. And so if any of this is happening, then be sure to let somebody know. There's also a policy on internet, social media as well. And again, if there's any concerns around that, make sure that you do come forward with it. There's just a few principles that probably most of you abide by this anyhow. First thing you need to do is check your security settings on your Facebook to make sure that it really is only for the people that you intend to see it. Posting any personal information about a patient or a colleague is not a good idea at all. Even writing on Facebook saying you had a terrible day, or I saw a challenging patient or whatever. Even those kinds of things can just be taken the wrong way, or somebody knows somebody who knows that person. So just being really cautious with putting anything related to work at all out there online is probably a good idea not to do. And even posting things about the hospital, providing medical advice outside of your work environment, also not recommended. And in fact, you may get requests from friends, from family members, for medical advice, and even for treatment or prescriptions, what you need to tell those people is that your license is only applicable to being a trainee here. And so you cannot practice medicine outside of an unsupervised encounter. So if you're in training, that's one thing, but if you're outside of an educational environment, you can't practice medicine. So that kind of gets you sort of out of those situations, and that's the truth. Otherwise, troubles can certainly happen. All right, so there is a policy on interactions with industry. We encourage residents to only attend accredited events and not have any interaction with pharma in the absence of your preceptor. We have a resident safety policy. And so basically, this is sort of the key from that policy is that you're excused from your duties if you feel that your safety is at risk. And you need to notify your preceptor or myself if you feel that you're in a situation where your safety is compromised. And so basically, some of the important points are that, if there are going to be any safety risks, that you sort of identify them, or your preceptor identifies them at the beginning of the academic activity. Weather conditions, especially around this area and our distributed sites, can be quite challenging. And then really, you shouldn't ever be working alone in the office. It's always important that a preceptor be present. House calls are a little bit different. So typically, the safety in those situations would be known beforehand. And so if you don't feel comfortable, though, making a house call on your own, make sure that you let your preceptor know. A lot of times the preceptor will go with you to the first house call, and then subsequent house calls, you may just go on your own, provided, again, that you feel comfortable and that you don't feel that you're in danger. All right, so residency can certainly be a stressful time. If that happens, just make sure that you know that you can talk to your friends and family, talk to your supervisor, faculty advisor, one of the chief residents. Make sure you have a family doc. Payroll has a list of family docs that are accepting residents, so make sure you take a look at that list. And you can also go to student health here at Western. Talk to me. We have confidential mentors that you can also access, and the wellness office is great also. They provide a great support. All right, we talked about that. All right, so, okay, I'm not going to go through all of these. Just know that they exist, and they can be found at the PGME website. Everybody gets a pager, so just make sure you know about your pager and know when you need to use it during your rotations. In terms of our leadership curriculum, Crucial Conversations is offered yearly. We're also working on being able to offer leader effectiveness training and personality dimensions, so we're hoping to get that rolled out in the next 6 months or so. And okay, that's enough from me for now. Yep. No, so that's a good question. So last year and the years before that, there had to be 16 direct observations done during your core family medicine. So now with the field notes, that's now obsolete. So you don't have to worry about getting those done. I think the field notes are a more robust way of assessing those types of things. Yeah. So direct observation is still part of the field notes. It's just they don't have to fill out those specific forms. All right. Okay. Are the chief residents here now? Yes. Okay. Come on up.
Hi. So to all the new R1s, just want to congratulate you again for making it here. Just thinking back to last year, it's a really exciting time. There are 3 chief residents. I'm going to introduce us right now. So I'm the chief for urban, so I'm Dan Sung. And this is Brenna Velker. She's chief of regional and rural. And in Windsor, we have Wendy and Wendy Kinnett. So that's our email below if you don't already have it. You've probably been bombarded by us a few times before to talk about the barbecue and the clothing sale. So you can contact us there. We also have a Facebook page called the Family Medicine Residents of Western, and we haven't added anyone there yet. A lot of people don't have their actual names as their Facebook names, so just send us an email to that, or you can add any of us, our actual names up there, our Facebook names as well, so you can PM us there and get on to our Facebook page. So together with a few other members of in the R2 year, we run the Family Resident Council, and we sit on academic and program curriculum discussions and committees. We also run a few social events, and basically we're asking for help right now as well. There's a few positions that need to be filled, and this is just to sit on a few discussions locally during this year's program. Provincially at the OCFP, nationally CFPC, there's a research committee, social coordinators, IT. So that's just ways for you to get involved with us.
And I really just want to echo what Dan said, that the getting involved in the Family Medicine Resident Council is a really great opportunity. You get to be involved in a lot of organizations like OCFP, those kinds of things that we're going to be involved with later on after we graduate. We have a lot of exciting stuff going on this year, and we need some help. So if you're the kind of person, which I'm sure you all are, who are interested in leadership and being involved and being leaders in your community as physicians, we encourage you to apply, and we look forward to working with all of you.
So this is probably the most important, what we can do for you. There's three big things that I want to talk about. And the first one is we're representing you at academic and program discussions. So this happens locally here, like I mentioned before. We have other members of family medicine representing you at the provincial level, at the OCFP, and then national at CFPC. And any information that's relevant, we feed that back to you. Secondly, we're trying to facilitate and really build a sense of community and collegiality. All of you are amongst your hopefully lifelong peers, friends, colleagues. You might even start practices with each other. So this is one of our strongest goals of this year, is to get everyone really involved in talking to each other, even if you haven't known each other beforehand. Lastly, we're here to support you. So anything you need about the program, initiatives, electives, we're pretty open to any emails of any sort. We're nice people, so just send us an email. And since we're up here, we're going to talk about this again. So there's a barbecue. We got a lot of great stuff going on, good food, lots of desserts, ice cream, activities for kids. It's a great day today. All the rain happened yesterday, so hopefully we'll see you out there. Bring your family. Kids are welcome. And that's just some of the details you probably know of before.
And the last thing we wanted to tell you about was the clothing sale. So we're going to do 2 clothing sales this year. This is the first one. So if you missed this one, you still have a chance to get some cool family medicine swag. But this time what we're offering is t-shirts and hoodies. There will be samples at the barbecue today if you need to try on for sizing. The way we're doing it this year is you click on that link and you pay online. You do everything online, so we don't have to be collecting your money and your checks, which makes it easier for me and more streamlined for you. The website will be open for 1 week after today, so until next Wednesday, so you can put your orders in online. Then we'll submit all the orders, and it should take a couple weeks for it to come in. We will distribute them at academic half-days. Any questions? Feel free to email us.
That's it.
Thank you. All right, so okay, so we are almost done. So I have a brief presentation on teaching skills for residents. It also dawned on me that these will be helpful skills in terms of just being a family medicine resident. I can probably have it done in 20 to 30 minutes, but do people want to break first and then come back, or just go for it? Go for it. Okay. All right. Okay, so why are we doing this? Well, as residents, you're often involved in teaching, and you play a very important role in that. And so to know some core teaching principles are very important. And so what are the goals for this session? Well, I'm just going to go through a couple models for you. So one is the 1-minute preceptor model. Another is providing effective feedback. And we'll just go through some questioning techniques and talk about how to tease out certain types of knowledge from a junior learner. All right, so where can you use the 1-minute preceptor? So that's really helpful for a setting like office and ER. It's also helpful in the inpatient unit as well. I've certainly used it there myself. And what this type of model does is it really helps encourage the learner to think critically through a problem. And as the preceptor, which you will be to the junior learners, it actually gives you insight into their clinical reasoning skills, which is probably one of the most important things to have as a clinician. The other nice thing about this model is that it's got feedback built into it. And so you never forget to give feedback because it's part of one of the key steps in it. And so it's called the 1-minute preceptor because it is very efficient. It does take a little bit longer than 1 minute, but you'll see it's pretty quick. And when you kind of see what the 5 skills or steps are, you'll recognize that this is what your preceptors are doing kind of day in and day out when they're reviewing cases with you. All right, so the first step is to get a commitment. And so the kind of question that you would use to get that is say, you know, what do you think is going on here? Or if you've kind of already established that, you know, what might the treatment plan be? And by having them put that kind of out on the line, it really gets them to commit and really then kind of forces them to sort of think through and tell you what they feel is happening. And as much as possible, try to avoid kind of jumping in and suggesting things, because not that that's not helpful, but sometimes it is more helpful if the learner can actually work through all of those steps internally before that sort of gets discussed. All right, so the second step is probing for supporting evidence. And so this is actually the step where you kind of explore how they got to what their most likely diagnosis or to their management plan. So was it a lucky guess? Sometimes it can be. But this helps you kind of figure out if it was a lucky guess or if they've gone through the appropriate sort of mental processes to get to that decision. So types of questions that you might use in this scenario are, you know, did you think about other causes for this or that? Or what made you rule out this condition versus that condition? And, you know, although, you know, questions like what is the differential of chest pain, they're still important, but they don't really get at that clinical reasoning piece as much as some of these other questions might. All right, so you've gotten your commitment, you've figured out how they've sort of gotten to that decision, and then at this point, it's helpful to provide some type of teaching sort of around some general principles, you know, a little clinical pearl, maybe, you know, something that they might consider the next time. And then this is where the feedback comes in. So the fourth step is to reinforce what was done well. That encourages that to happen going forward. And then the fifth piece is really just to point out any errors or sort of what they might do differently the next time. So I don't know, does this seem kind of familiar to people? Can they see that their preceptors are sort of doing this with them? I see some nodding over here. All right, so I'm going to show you a video. So I think that it's helpful to see the video, and I'm going to cross my fingers that the audio works. Yes, all right.
Try improving your teaching skills with this classic 1-minute preceptor technique.
I didn't make the videos.
So, what have you got there?
This is a 45-year-old woman who fell down 3 steps, and she landed on her right outstretched hand. She has some pain and swelling over the lateral part of her elbow, when I examined her, as well as some pain over her distal radius. Her elbow flexion is also decreased, and she has pain with supination.
Okay, so what do you think's going on here?
I think she just has a simple sprain of her elbow and wrist.
Okay, did you think about anything more serious?
Well, I looked for fractures on the x-ray, and I didn't see any fractures of the elbow or the wrist. And when I palpated over her snuff box, she didn't have any pain or tenderness, so I think a scaphoid fracture is quite unlikely.
What we'll do is we'll go and take a look at the x-rays, and when we do, I want you to take a good look at the lateral view of the elbow, and look for a Sale sign. So you see that when the fat pad's elevated by intra-articular hemorrhage, and that sometimes can be the only sign of an occult radial head fracture. So let's go take a look.
Perfect.
You were right to think of a fractured scaphoid with that mechanism of injury. But I think with the lack of tenderness and the normal x-ray, I think that rules it out. But I do think she probably does have a fractured radial head. If you look at this Sale sign here, you can see the elevated fat pad. And even though we can't see a fracture on the radial head itself, we can infer it from seeing that. So I think we should treat her for that.
Okay.
So we'll go back and see her.
Sure.
All right. Okay, so we'll move on to providing feedback. So why is feedback important? Well, it's important to continue doing what you're doing well, moving forward. But it's also important to understand maybe where things went wrong or didn't go so well to be able to modify them, to do them differently the next time. But oftentimes receiving that type of feedback is obviously a little bit harder than receiving praise. And so if there's a few things, so as residents, when you're doing teaching, you'll still have to give some constructive feedback as well. And so when you do that, there's a number of things to consider. So the first thing is that just make sure you've got a safe and supportive environment where the learner feels that they can ask questions, kind of put things out there without being criticized. Always let the learner know that you plan on giving feedback. And it's important to let them know that, feedback happens sort of on an ongoing basis. It's not just at one point in the day. It's often throughout the day as you go. And sometimes it's helpful to sort of say, let me give you some feedback on that. That way you're just kind of labeling it and they're aware that that is specific feedback that you're giving to them about that incident. And sometimes it's helpful to actually ask the learner if there is an area of their performance that they want feedback on, rather than assuming that it's maybe this or that. Getting their input as well is obviously important. So a few things. So one thing to consider is that it should be descriptive rather than evaluative. So what that means is, so rather than saying something like, you just didn't appear interested in Mr. Smith's social situation, that's kind of imposing your judgment and being a little bit more evaluative. So a better way of saying that provides a little bit more description and a little bit more direct feedback is basically to say, you need to remember to acknowledge both the social and the other medical problems that the patient is coming in with. That just gives a little bit more specific and concrete feedback. Which then leads nicely into my next point, which is try to be as specific as possible. And this is also very relevant to doing your field notes. So field notes are also a means for you to sort of track the things that you've learned and the things that you might do differently based on an encounter that you've just had. And so that reflection piece is extremely important as a clinician. And so, it's not to say that you can't write things like, I took a very detailed history. Like, that's certainly important. But if you can be a little bit more specific, like saying, I asked about all the cardiac risk factors and identified those very clearly, that is just, it's going to give you a little bit more insight rather than just sort of, did a good history and physical. And then making sure it's balanced. So you never want a learner to leave having just heard negative feedback. Always make sure that you're adding in some positive things there as well. And there's always some positive things you can find. And just make sure that the timing is right. So what's the right timing? Well, giving it often, giving it as close to the event as possible, and making sure that, especially for negative comments, that you're in a more private environment. And again, kind of in the same line as the balanced one, make sure that it's limited. So there may be 10 things that you want to give feedback on, but that might be a little bit too much for the learner to process. So just pick one or two to provide some comments on, because brief and focused feedback will have a higher impact than touching briefly on or just sort of skimming the surface on a whole bunch of different items. The other thing too is that you need to make sure that it's something that they can fix. And so this was an example that was given on a teaching website that was giving some thoughts about feedback. And so, if you say to someone, the patient can't understand your accent, well, that's just not helpful, because those things are sort of out of your control. So, but sometimes if you say, well, maybe if you talk more slowly, that will be more easily understood. So that is some type of feedback that is a little bit more helpful. All right, so again, the key points are, get the learner's ideas as well on what went well, what didn't go that well. Reinforce the positive, but correct mistakes. And the second to last point there is really important. So it's important to give the feedback, but it's also important to have a plan for going forward, to make sure that the next time that feedback gets incorporated to future sessions. And there's something called the McMaster feedback sandwich, where you sort of start with something positive, maybe have something negative or constructive, and then end on a positive note as well. So that's something that how you might kind of frame a feedback session as well. All right, so I got another video.
Providing effective feedback improves clinical skills for all learners, not just those who are struggling. This next lady's here to review her abnormal liver function tests. Why don't you take a look at her, and I can give you some feedback about what I see. Anything you'd particularly like feedback on?
Well, I'm not really confident about my abdominal exam, so maybe you can observe that and let me know what you have to say about it.
Sure, sounds good. Hi there. This is Chris. He's a medical student working with me. He's going to be checking you over. I'm just going to stay here and just make sure everything's going smoothly.
Okay, so I'm just going to examine you now. Why don't you lie down? Okay, I'm going to take a peek at your face. And I'm also going to look at the whites of your eyes. And take a peek at your hands and your fingernails. Okay, and would you mind lifting up your gown for me? And I'll take a look at your abdomen as well. Okay, sounds normal. And I'm just going to have a feel and let me know if you feel any pain. Could you take a deep breath in for me, please? Okay, and out. And another deep breath in for me. And out. All right, thank you very much. We'll just give you a few minutes to get changed, and Dr. Hindle and I will be back.
So, how do you think it went? Is there anything you were pretty happy about?
Well, I remember to check for jaundice and some of the extra abdominal signs of liver disease, so I was happy I didn't forget that.
Yeah, those were particularly good pieces of the examination. I think it's really important to do that. Anything that didn't go so well?
Well, when I was feeling for her liver, I really wasn't confident if it was enlarged. I didn't get a good sense that I really knew the size.
Right. So it's sometimes difficult when you're just palpating. Was there any other technique you could have used that might have made it easier? You listened, you palpated.
Percussion.
Percussion, right. So if you want to be sure whether the liver's enlarged or not, then percussion's really going to help you.
Right.
There was one other thing that I noticed, that when you were listening, when you were feeling her abdomen, she was still sitting up a little bit, and it's much easier if you lay her flat. So next time when you go along, then I think it's really important to remember to percuss the abdomen, but make sure about your patient positioning.
Flat, right.
So let's take a look at her results, and then we can figure out what we're going to do with her and go back in and talk to her. Okay?
All right, sounds good.
Oops. All right, so in that scenario too, I mean, there were lots of other things he probably could have commented on for feedback, but he's, solicited the learner's thoughts and ideas too, and just kind of sort of focused on the areas that he brought up. So the last piece that I wanted to talk about is just how to use the questions that you ask, just in an efficient manner to get the most out of that clinical encounter when the encounter when you're giving feedback. And so there is a bit of an art to it, and that's certainly something that you will develop over time. And again, why are we using questions in the first place? Well, it's really to help us explore not only the learner's knowledge base, but also how they work through a clinical problem. And so there's different types of questions depending on what you're trying to tease out. So if you're purely looking at knowledge, and that's mainly sort of recalling facts, then you can say, what are the symptoms of MI? And that's going to help give you some information. If you want to look a little bit more at understanding and interpretation, you might say, well, why do people feel pain, let's say, in the left arm if they're having some cardiac ischemia? And then if you want to explore their clinical reasoning, you might then sort of ask questions about, patterns, looking at the relevant data. And so questions like that, would be sort of more like, well, do you think this patient's having an MI? And that's more like, then they have to incorporate, their history, their physical exam skills. They might have had to look at an ECG or some blood work that the patient's gotten back. And again, too, asking those sort of higher level questions of, how do you distinguish between diagnosis A and diagnosis B? And that gives you a little bit more information than the questions on the earlier slide. And then this is, again, another higher order question where you might reserve for sort of more advanced learners. But they're questions like, does this patient need to be transferred? So if you're in a more rural site and they've got something going on, can they work through that process of looking at the big picture and deciding whether or not further intervention needs to be done? Questions about prognosis, kind of throwing something in here. Well, there's scenario A is happening, but what if the patient also had impaired renal function? How would that alter your management, or how would that alter the outcome in this scenario? All right, and so again, this is another higher order type of questioning, but this gets at the reflection piece. And so, like I mentioned too with the field notes, this type of reflection is important for clinical practice. And so after you've had encounters that went really well, and after you've had encounters that haven't gone so well, it's important to think about how you might do things differently, or even the same for next time. Maybe things that surprised you, because those are the things that you're really going to learn from and be able to sort of keep in the back of your head when you're seeing other patients with similar conditions. All right, so these are the last two videos. The first one is funny, so here we go.
Well, 64-year-old man, painless hematuria. What's the differential?
Well, there's renal stones.
Yes. And what else? Come on. Don't they teach you anything in medical school these days? I suppose they're so busy talking about how the client's feeling about their discolored urine they don't tell you what you need to know to save patients' lives. Come on.
Infectious, vascular.
Come on. You must know the key causes of painless hematuria in a 63-year-old male. Anticoagulation, AV malformation, polycystic kidneys, hemoglobinopathy, glomerulonephritis, SBE, malignancy, prostatic hypertrophy, renal stones, and finally...
Finally?
I
don't know.
Schistosomiasis.
Schistosomiasis in Edmonton?
Okay, so don't do that. Reminds me of Dr. Cox on Scrubs. All right, so I don't think you'll encounter preceptors like that in our program, but this would be a better way of approaching that scenario. So.
Quizzing can be a great way of teaching, but there's a right way and a wrong way to find out what your students know. So, 63-year-old man with painless hematuria. Any thoughts what might be happening?
Well, I was initially thinking about renal stones, but now I'm thinking he's an older guy, so malignancy is also a risk.
Those are really great thoughts. Anything else that you were thinking about? I was thinking about maybe, an inflammatory cause.
Like glomerulonephritis?
Yeah, exactly. Anything in the case that makes, favors the malignancy or stone over glomerulonephritis?
Well, if it was glomerulonephritis, we should see some protein on the urinalysis and maybe casts when we looked at his urine, and we didn't see any of that.
Absolutely. I think you got it exactly right. I think what you've said, we've got to really rule out those two causes, stone and malignancy, and go from there. Now that you had a chance to think about it a little bit, is there anything else you'd like to ask your patient when we go back and see him?
Well, we were talking about malignancy, so maybe occupational history or a fuller social history might show us some risk factors or point us in the right direction.
Sure. I think that'll add something to the case, so why don't we go back and do that?
All right, sounds good.
All right. Okay, so that's it. So I just have a few summary slides. So don't forget the 1-minute preceptor, fast and efficient, get a commitment, probe for understanding, teach some general principles, provide some feedback, and correct some mistakes. When you're giving feedback, remember to be descriptive, specific, timely, balanced, limited, and focus on things that can be fixed. And then when questioning, think of all the different types of questions. And you saw in that last video, he used lots of different types of those. So just make sure that you're mixing it up when you're teaching your medical students and junior residents. And that is it. Any questions at all about this? No, there's also other teaching sessions offered through the continuing professional development for residents specifically for teaching skills. So if you have an interest in that, make sure that you check it out. There's also the possibility of doing an elective in, what's the official name of it, Sharon? You can do an elective where your focus is on teaching. You do it during your during family medicine. Britta did it a couple years ago. Nobody's done it since. Anyhow, you can, if you have a strong interest in teaching, it's possible to do an elective where that's your focus.